Stroke is the leading cause of adult disability. Many can't walk or use their arm. And most of us know from friends, family, loved ones that there's a little bit of recovery, and some have a substantial amount, but no one gets it all the way back.
The physical work to recover from a stroke can be taxing and it's often limited. But what if there was a pill that could actually retrain the brain? On the brink of answering that is neuroscientist and neurologist, Dr. Thomas Carmichael. Welcome to Brain in Progress. I'm Seema Mathur, a medical journalist and brain champion. When I visualize Dr. Carmichael, it's with a stethoscope and microscope.
I had done a PhD with my MD, and that was to develop really fine-tuned mapping of brain connections. When you do the precise mapping, you find in every individual, there's just an odd connection that comes from this place over here, or that place over there, just a few cells. And I thought, if the brain connections aren't exactly hardwired, and there's a randomness to a small number of them, maybe that's because they just sprouted a connection that they weren't supposed to. I thought, what happens if you can get spontaneously odd links in recovery? That's kind of what I had in my head when I first started this work.
That was decades ago. Decades of work to build on that has led Dr. Carmichael to where he is now. He's the professor and chair at the Department of Neurology at the David Geffen School of Medicine at UCLA. So, Dr. Carmichael, thank you so much for being with us here today. You studied the brain on a very deep level, on a molecular level. In your study of the brain, why did you decide to zone in on stroke versus any other type of brain injury or brain disease?
It's mostly impact. After a stroke, most don't return into the same community or work participation they had before. And so it was the demand, the need to try to understand how to better improve recovery in stroke.
And when we think about recovery, it goes to neuroplasticity, the brain's ability to repair. What is neuroplasticity? How would you define neuroplasticity?
We might start with what is not plasticity and work our way there. So normally the brain has a wide network of connections and it keeps those fairly constant. If you learn a golf swing, you don't want to all of a sudden have your connections scramble, or you just saw a great movie, cried at the end. You want to remember the emotional context, all those connections. You can't afford those connections to scramble and change. But plasticity is when they deliberately change in response to some stimulus, some new signal in the environment, or some new training paradigm in stroke, or a drug, causes the connections to change, to kind of mold into new formats. So that's the vision of plasticity and the change in connections.
So these important connections that get confused, or in the case of stroke, also die off. And so I don't want to bury the lead too much. So I want to come back to all of this a bit deeper. But when we talk about this pill that could help the brain recover, what is it? What have you been studying?
So what we found is that paradoxically, the brain activates systems to lock its connections down, to prevent plasticity. And that limits recovery. And one of the main ways it does that is it activates a molecule that makes a brain cell, a neuron, less able to grow a new connection. We are able to block that molecule and reverse it, to open the brain up to new connections and new plasticity.
What is that name of that molecule?
The molecule is abbreviated CCR5, and it's a receptor normally involved in the immune system, and it's hardly even turned on in neurons or brain cells. The remarkable thing about stroke is it massively turns it on, and it does so in the areas that should recover, and it locks those areas down.
So we all have this molecule, but in stroke, it just turns it on and is blocking functions.
Yes,
The aim is to stop that from blocking functions.
exactly. And to allow neurons to be more nimble, to be able to kind of respond and form new connections and to help recover.
And so leading to the study that's happening now to see if this is actually going to work in stroke patients, it was testing a drug that was originally used for HIV patients. How did that come about?
It's one of these fascinating, unexpected overlaps in science. And so we had no work in or relationship to HIV/AIDS research. We're simply focused on molecules that might enhance the formation of new connections and plasticity after stroke. Sometimes in science, we're in our silos. I wasn't aware that the CCR5 molecule actually had a more prominent role in the HIV field. It's the co-receptor for the AIDS virus. And so there's a deep drug company interest in blocking it for HIV/AIDS. And so we were able to say, well, if we're blocking it in HIV/AIDS, can we just transfer it over and block the same receptor, but in the brain and stroke? And that's what we sought.
That's amazing. So it's like, first of all, you had to identify that this CCR5 was a big deal in recovery, and then making the connection with another unrelated drug that fortunately is already FDA approved.
Yes.
What do we know about the side effects of this drug that because it has been in use for HIV patients?
They're relatively minor. It's a fairly safe drug. Roughly 15% of HIV patients are on it. In some small number of patients, it can cause some inflammation of the liver. So we screen for that. That's the main side effect.
What is the status of the clinical trial, and how long will it take before we get answers on if this is going to be effective and safe?
The clinical trial's just over a third filled with subject entry. This is Dr. Sean Duclos in Canada running this. And so it's likely in a year and a half, we'll have completed subject entry and be in data analysis mode.
Can patients sign up for this trial still?
There are a number of constraints. It's, of course, in Canada. That's one. It's also closely designed to follow what we saw in the mouse model of stroke, in which we saw efficacy with this drug. And so the timing is 2 to 6 weeks after stroke, fairly early in the post-stroke phase. So that's another constraint. Most stroke patients are in the chronic phase, which is more than 6 months after stroke.
So, what is that window of opportunity?
What we know, if you follow thousands of patients in stroke, is there's several phases of recovery. The first phase is when all the death and damage happens. The blood clot has occluded the vessel, there's no oxygen to that part of the brain, and that part of the brain dies. That lasts about 5 days. The next phase goes from 5 days to 3 months. And it's when most patients make their most substantial recovery. That's called the subacute phase. Sometimes the subacute phase is 3 months, sometimes it goes to about 6 months. After that is chronic. Patients have to work harder to recover. They still can. It just takes a lot of work, and it's usually more focused in one area. So if you want to recover skilled use of your hand, tons of work over and over with the hand is required in the chronic phase. Whereas just before that, in the subacute phase, the brain is more plastic and recovery can occur with less intensity.
Wow. So, what is happening in the brain in that phase where the brain is more plastic? Can you liken it to the plasticity window of children? It's like when you say, okay, this is the age that you can learn a language the best.
There are many similarities. In children, it's called the critical period, where the brain is really open to change with a new language. Or if, say, something's wrong with your eye and you don't see well out of an eye, there's a window of time where if you get that eye going again, the brain responds and is normal because it's so plastic. It's a critical period in development of great brain change in response to a new stimulus. And then it closes. And so the analogy in stroke is just like that. You really hit the nail on the head. Rather than call it a critical period, people have coined the term sensitive period. There's a sensitive period of greater brain plasticity in the first 3 months in humans after stroke that is something that we should try to hop onto and magnify. And that's one of the goals here.
Is that the time for stroke patients to really do traditional rehabilitation? Is that when they would see the most results?
It is when they would see the most results. As a matter of fact, clinical studies have shown it even varies by week. And so in those first 3 months, when you look at the recovery each consecutive week, the earlier is even the greatest.
And the irony on that, it's like when you can get the best brain rehabilitation is also when you're feeling the worst for
Yes.
the patients. Like how hard it is to get up and to do anything when you're in that state. So it's all the more reason that a pill is so important because it's not like this is a magic pill and you don't have to do the work. Or maybe it is. I don't know. I guess I should ask you that. Would it replace traditional brain rehabilitation?
No, it probably wouldn't for a number of reasons. One is that rehab has, even though it's physical medicine, it still is uniquely successful at activating the brain circuits we want to improve. So the most common stroke is in one territory, arterial territory of the brain, and it affects arm and hand control. And so when we force people to use the hand over and over, we're using those brain circuits that control hand movement. And what the idea here is, let's get those circuits firing together quite a lot with rehab, and then give a drug that stimulates them to be even more plastic and reconnecting.
So, in the brain rehabilitation, is that making new connections in the brain for the hand to move, or is it strengthening what was injured?
And the answer is both. When you do human functional MRI and map brain connections in patients who have had stroke and then successfully recover, what you find is early after the stroke, if we're talking again about the hand, the network of brain areas that move the hand aren't firing together. They're not coordinated and active. And those who recover successfully the best get those areas back and firing in a network together that they should. And so that's the best recovery option, is to bring back online the network of areas active together, to use language or to feel sensation or to move a hand. Minus that, say the stroke is big or areas aren't able to reconnect, come back online. The second principle is what you also brought up, and that is, let's get new connections to form. Let's stimulate an alternative network that might recover that function.
It makes me wonder about brain reserve, right? Because the difference then in an adult versus a child is the brain remembering, I used to know how to move my hand. So now I'm going to move my hand. So is it the more active a person may be, or the more experiences they may have in life, if that impacts the neuroplasticity or the recovery?
Not so much. It's clearly so for Alzheimer's disease and dementia. There's a brain reserve and a brain resilience that are tied to educational level and certain job categories. But in stroke, we don't see that link as much. What we do see is the link to the intensity of the therapy, how frequently it's given, and the type of therapy. And then we see a strong effect of age. The young brain just recovers better than an aged brain, but we don't see quite the element you're getting at where you might have built up some cognitive capacity, some reserve, because you are a Nobel laureate and you're going to recover better. But in dementia, we do see that. We just don't see that in stroke recovery.
It's exciting for me, and one of the motivations to do this podcast is because I've been so fortunate to recover from a lot, and I don't even know exactly how that is, the mechanisms of how this all worked. The first brain condition I had was an acoustic neuroma at 19 years old that was a more than 4 centimeter golf ball sized tumor pressing on my brainstem. So it was quite large. At that time, that was 1,000 years ago at 19. I had never heard of the word neuroplasticity. That was not really around. So after the surgery, I had to kind of regain balance, to walk. When I went back to school, to university, because I was a student then, I went from basically an A student to failing and not being able to find my dorm. But I realized that the university was my neuroplasticity lab because I was eager to get back. I didn't want to stay in bed and recover as I was told to. I wanted to go back to school and I had to walk. I was walking all the time. I was learning. I started to do yoga. And so I built back and built back. So, do you think that those particular elements, do you think university was really my neuroplasticity lab?
There's a couple of different principles at play here. One is that you had a focused effort to engage in activities that you weren't doing well. It sounds like a lot of it was involved around learning, cognitive processes. And some of it, it sounds like, involved gait or motor control. And so you were doing both. You were in a university environment engaging cognitive processes of learning, and then you were walking and practicing gait control. And so those are two areas that you were specifically deficit in and stimulating. And that's what we found is there is a need to really stimulate the area that's impaired. So for you, it wouldn't have helped to sit there and play a video game and get your visual and spatial functions going. It doesn't sound like you're having a problem with that. And playing video games wouldn't have transferred to gait. If the impairment is in word finding and language use, then that's where the activity should be. But you're right, it's activity dependent. It's not rocket science here. It's the old use it or lose it. It's almost like a drug. It's a dosing effect. The greater the dose, the greater the recovery.
So when you talk about the drug and going back to the drug you're studying and the dose, many drugs just sort of appease a side effect, right? Instead of actually fixing the problem or make you not feel pain, but it's not fixing the pain. But in the case of the drug that you're studying for stroke, is it actually fixing the problem, the source?
We can only answer based on what we know from the laboratory studies. And what we found in stroke models in mice is just like in humans, part of the brain dies from the stroke, and then areas around it that should be mediating recovery further lose connections. So there's a secondary and delayed loss, even areas distant to the stroke. And what the drug does is blocks that and prevents that distant loss of connections. And then it helps some of those injured cells form new connections to additional areas that might, in this case, move a limb. So it reduces the number of connections that are lost, and it helps form alternative new connections to control, in this case, limb movement.
So, what could we expect? Could you describe a patient that is impacted by a stroke? They take this drug, and what's the hope? What's the difference that we would see?
The system that we know worked in the lab, we know is responsive, and that's movement or motor control. 60% of all human stroke occurs in and around areas that control the arm. And many patients complain about inadequate recovery in arm control. They just use the other arm. What we really want to see is a skilled and meaningful recovery in that affected arm.
Amazing. So, the hope is that somebody that loses use of their, say, right arm after a stroke would be able to use their arm again as if they never had a stroke.
That's a tall order, as if they never had a stroke, but we really want them to have their arm functionally integrated into their activities of daily living, integrated into skilled and daily use.
I'm sure people that are listening to this are going to think like, "Oh gosh, this is going to be out and my window of opportunity passed." Do you think the drug could still help people even past that window of opportunity?
So your question is, in chronic stroke, longer than 6 months, is that receptor still there so we can block it? And can we get the drug into the brain? And we just don't know the answer. In mice in our lab, we found in chronic stroke it did work. And so there's hope that if it works in the easiest target, which is this earlier stroke time point in humans, the subacute period, if it works there, the hope is then we could go to chronic stroke. We're probably going to have to pair it with really intensive rehab.
Do you think that if this drug proves helpful and safe in stroke patients, that it could be applied to other brain injury?
Yes, we do think that. We found that it worked in mouse models of traumatic brain injury. And so that would be another target here.
Why do you think the brain that is so important that it's taken so long to be able to unravel the mysteries and be able to get the right help to the brain or to understand the brain?
Yeah, there's several answers to that question. One is historically, it was felt the brain does not spontaneously repair and recover. And that's been considered for the last century and 20 years. The second is it's really hard to study in real time. In skin, you get a wound and you can follow it as it repairs. Or even in liver or kidney or heart, there's imaging where you can follow the repair. The problem has been in the brain, you can't. It's hard to follow markers for repair and to map it as much as in other organs. So those are some of the main reasons we've lagged in the brain.
How many years would you say you've been studying the brain?
Well, I've been on faculty since 2001, so there's 25 years. I had 3 years of fellowship before that where I was studying the brain. So at least after my schooling, that's 28 years.
I was thinking about it because there's such intense perseverance that you have had to have, ups and downs, but you keep working. Like you are finding different pathways to the answer. You are having to persevere. So, in a sense, it's like your work is similar to the stroke patients or brain rehabilitation patients.
Yeah, the analogy is I'm using the same activity pattern over and over again to stimulate new connections. There's two things that keep, I think, most of us going who are physician scientists. And the first, of course, is our patients and their suffering. And it's such a driver every time I have clinic or I round in the hospital to realize this patient will not recover their arm use or their functional use of language. And we have to develop a drug that enhances that. The second, at least for me, is that medicine itself can become algorithmically driven. In fact, we read in the paper, we're trying to use AI, just to use large language models to link words together to come up with ways to understand disease. It's becoming kind of rote. But science and thinking about new medicines is purely creative. It's a very creative pursuit. The lab is just full of energy and enthusiasm for new discoveries. And so that's a second and powerful motivator is the creativity and the alleviation of human suffering.
That's right. I mean, you have to have a creative brain to even pull together a drug that is being used for HIV and think about testing that, or creative in the sense of identifying the gene. So I'm curious on the philosophical, in your view of the brain, like you're seeing the brain on a level that most of us never see on this very molecular level. How do you think that the brain makes us who we are?
We are not a standard template of brain wiring. We all have unique and odd, unexpected connectivities in our brain, areas that connect to each other that others don't have. And so I think one aspect of this is that our brains are all individually highly unique, even in something as simple as our wiring. And that leads to unusual ways of doing things, seeing our world, and responding.
So, from all that you know about the brain as well as your molecular view, how does it make you see yourself and the world?
I see myself as a small and individual actor, at least in one level. We've had great success in the lab, and we could think about brain science, the philosophical aspect of being. But I tend to want to live small, to focus on what I can do in my science with my patients or in my community network myself. What are the elements most important to me? And I don't think about sort of living large. So for me, the most important things are to understand what's important in my world and what I can influence and impact, and just to do that in my own way.
Well, your small contribution is going to have huge impact. We're very grateful for your focus and your study.
Well, thank you. This has been a great discussion.
Thank you so much. I don't know what it's like to walk around every day with your brain having all that information about the brain.
Well, thank you.
This episode was produced with Julie Canfor, editor Mike Sines, sound engineer Jason Gamble, original music Yuval Ron, social media Ashita Patel.
This is really like a man on the moon moment. This is something that brain surgeons and patients have waited for many decades.
In our next episode, can a brain implant help deliver medicine to the brain, bypass the blood-brain barrier, and significantly extend the lives of those with brain cancer? You can listen wherever you get your podcasts, watch on Brain in Progress YouTube channel, and go to braininprogress.com with the link to all of our platforms, as well as how you can stay up to date and support us. Please check out the podcast Peaceful Exit by my friend Sarah Kavanaugh. Please remember, the health information shared on this podcast is not a substitute for individualized medical care. Always consult with your doctor. Thank you so much for listening. I'm Seema Mathur with Brain in Progress.